Can we hit recording يا شباب? Okay, excellent. طيب. بسم الله والصلاة والسلام على رسول الله. Thank you all for joining us today. This is the second live streaming session from King Abdulaziz University Hospital, focusing mainly on endoscopic interventions, and we are very happy and thrilled to have you again joining us in another interesting and outstanding talks and topics about one of the most related clinical problems we are facing and seeing in our clinics related to gastroesophageal reflux disease. At the beginning, I would like to thank all the supportive staff, audiovisual teams, nursing, and trainees who are going to be actually joining us today and this live streaming, trying to make this come out the best way, and hopefully that you're going to enjoy us. At the beginning, just a quick reminder that our topic today will be about gastroesophageal reflux disease, about how to approach these patients, which is going to be presented by Dr. Mohammad Alzahrani, our colleague in ABHA, who actually is a well-known figure in the motility studies. And Dr. Abed Lehaiby as well, our super interventional gastroenterologist and advanced therapeutic endoscopist from King Fahad Medical City in Riyadh. So I welcome both of them today. And at the beginning, I would like to invite Dr. Mohammad Alzahrani to start his okay. So it seems like we are having issues with Dr. Mohammad Alzahrani joining. Okay, so we will figure it out. Dr. Abed, are you with us?
Yes, Emad.
Okay, excellent. So, Dr. Abed, I would like to welcome you today, and I know that you have a very busy day, very busy clinic and procedures, and we really appreciate joining us today. So, if we could, maybe we can start with you in 2 minutes if Dr. Alzahrani is not able to join. So, I'm going to put you on the major screen for now. Yes, Dr. Mohammed joined?
Yeah.
Yes. Okay. Welcome. Thank you. Saved us. So Dr. Mohammed will be actually presenting his first presentation. So please take the lead and the stage is yours.
Okay. Thank you, Dr. Abed. Thank you, Dr. Emad, for inviting me. And thank you, Dr. Abed, and thank you, Mr. George, for having me for this event. Dr. Emad, if you can share me the screen, because I cannot share the screen. Dr. Emad? Dr. Emad, do you hear me? I cannot share a screen. Yes, now it's good. Okay.
Actually, sorry, you can try now. I think it's up.
Okay. Thank you, Emad. Thank you. So today we are talking about the approach to the diagnosis and management of GERD. I have nothing to disclose. The topic we're going to talk about the new definition of the GERD and the clinical manifestation of the GERD, mechanism, physiology as well, and we'll talk about the diagnostic consideration, what, when, and how to interpret the results. And we'll talk briefly about the updates on the GERD management, and then we'll end up with the summary. So the definition of the GERD, as you know, the most important one for AG junction is valve. This valve, lower respiratory sphincter valve, is augmented by diaphragm that keep the valves closed all the day when patient is not swallowing to prevent the gastric juice to goes back again to the esophagus. But if there is any failure with the LES function, so that will allow the reflux goes back to the esophagus and causing the symptoms. The old definition for the GERD was the Montreal Consensus that published in 2006 and defined the GERD as a condition which develops when the reflux of the stomach contents causing troublesome symptoms and or complications. But the ACG guidelines publish the definition of the GERD They define the GERD is objectively defined by the presence of the characteristic mucosal injury seen at endoscopy and or abnormal esophageal acid exposure demonstrated on the reflux monitoring study. Also, the Lyon Consensus published their guidelines recently, and they defined the GERD. The modern definition of the actionable GERD require conclusive evidence of reflux-related pathology and endoscopy and or abnormal reflux monitoring in the presence of the compatible trouble symptoms. So we are dealing right now with the proofing GERD and improving GERD. That proofing GERD, there is objectively seen the mucosal damage on endoscopy and or abnormal acid exposure on ambulatory pH testing. So the manifestation of the GERD, whether patient present with the esophageal symptoms, classical one, or extraesophageal symptom, or sometimes they can mix it between esophageal and extraesophageal. So the esophageal one, the manifestation, whether typical reflux syndrome or reflux chest pain as well, or if there is any mucosal damage on endoscopy. So that one, we call this one reflux esophagitis, reflux stricture, paresophagus, or esophageal adenocarcinoma as last complication from the GERD. Or could be patient present with extraesophageal syndrome like cough syndrome, laryngitis, asthma, dental erosion as well, or it could be with the pharyngitis, sinusitis, idiopathic pulmonary fibrosis, recurrent otitis media. So a patient present with extraesophageal syndrome, the correlation with the reflux still is not that well known, but one of the causes for the extraesophageal syndrome. The mechanism of GERD. Actually, reflux is a physiological process. In normal person, you found the esophageal acid exposure less than 4%, and reflux episode less than 40 reflux episode per day, and require the gas ventilation. So we have normal defense mechanism of reflux. First one, by lower esophageal sphincter, fundus compliance as well, diaphragmatic pinch. Secondary peristalsis to clear out the esophagus after swallowing, or if there is any refluxate in the esophagus. Also, salivary production, one of the most important defense mechanisms to buffer the acid as well, frequent swallowing, and epithelial barrier function. But the question now, why do patients get symptoms of GERD? Potential etiology. The first one is the gastric one. With the obesity, and the obesity is linked right now to the GERD, and also with the reduced funding compliance. Or if there is any failure with the gastroesophageal junction, whether with the hiatus hernia or hypotensive lower esophageal sphincter, or increased transient lower esophageal sphincter relaxation episode. Also, if there is any thing that affect the esophageal body that affect the motility like scleroderma, or with the decreased salivation like Sjogren's syndrome, or if patient have heightened sensation or awareness with the esophageal hypersensitivity. For the refractory GERD, the patient is not responding to the PPI. So the first important one to look for the proper dosing and compliance with the medications. So a patient is not compliant with the medication, or having improper dosing or nocturnal acid breakthrough, reduced bioavailability, difference in metabolism, H. pylori status as well, PPI resistant, delayed healing, residual acid reflux, all this contribute to the continued acid production. Or it could be other reason for that refractory GERD. It could be with a weakly acidic or alkaline reflux. Or it could be alternative diagnosis. The first very important one, if you have patients with refractory GERD, should exclude the other possible causes. The first important one is the achalasia, or it could be esophageal cancer, gastric pill-induced esophagitis, gastroparesis, EOE, one of the top differential diagnosis for refractory GERD, and rumination syndrome. Or it could be overlap, or patient having the functional one, we call this one visceral hypersensitivity, functional heartburn, or psychological overlay. So we are dealing with the reflux spectrum. If you have acid exposure, so ended up with the erosive esophagitis, there is a mucosal damage endoscopy, or endoscopy is normal but abnormal pH testing, we call this one non-erosive reflux disease. But if the acid exposure in normal site or it could be mild acid, but still the patient have symptom association with the esophageal hypersensitivity. We call this one reflux hypersensitivity or functional heartburn. What are tests available for GERD? The first question, how is GERD diagnosed? Either by PPI testing that responds to the anti-secretory therapy, or endoscopy, or pH. As you know, the new definition right now, we should have either endoscopic finding that mucosal damage with esophagitis, or abnormal pH testing. The PPI testing, this one you can start for a patient present with a typical or classical symptoms. You can start with the PPI, that empirical acid suppression with PPIs make native sense. But the new systematic review of 15 study using normal or high dose of PPI therapy for 1 to 4 weeks. The sensitivity is around 78% and specificity only for 54%. But the average cost around $570 per patient. When to perform endoscopy, actually patient present with the alarm symptoms like dysphagia, weight loss, GI bleeding. The dysphagia is still one of the alarm symptom is maybe related to the reflux, but if it is predominant symptom, that dysphagia, so the patient is should have the endoscopy. Or inadequate response after 8 weeks of empirical trial, symptom recurrence after discontinuation of PPI, chest pain without heartburn or normal normal cardiac workup, patient with multiple risk factors for Paris, and those patients need endoscopy. The sensitivity is around 50% at the best and 10 to 20% in the most serious. But the new recommendation right now from the line, the endoscopy should be done after discontinue of PPI to maximize the yield of diagnostic endoscopic finding, to find this patient having the esophagitis class grade P, C, D, or having, for example, alternative like EUE. When you perform endoscopy, it is very important to grade the erosive esophagitis by using LA classification, grade A, B, C, D, and inspect for the diaphragmatic hiatus hernia by using the HEL classification. As you can see here down, the HEL grade 1, grade 2, 3, and 4, and you should measure the axial hiatus hernia length, and to assess for Paris esophagus by using Prague classification. And it's a very important one to exclude the other causes, especially in dysphagia like EUE, achalasia, or malignancy, or peptic stricture. The ambulatory pH still that allow the objective measurement of total acid exposure. This provides as well the correlation between symptom and acid exposure. Until now, it is the most sensitive one for diagnosis of the reflux. And the recent study showed the patient with refractory reflux on PPI, they found abnormal in third patient of once daily PPI and abnormal in 4 to 7% if in patient twice PPI. So we have two kinds of ambulatory testing, either catheter-based study, and this one is traditional. The traditional one look for the acid reflux, but the catheter-based right now we have impedance one that can assess for the weakly acidic and alkaline reflux. So the increasing data suggests on the acid reflux may cause the symptom, especially with atypical symptoms like chronic cough. And impedance one evaluate for reflux using the difference parameter folds and all types of reflux events. The wireless pH, the Bravo one, it is placed above LES, 5 centimeter above LES, and this one is accompanied by endoscopy. You can place it by endoscopy, no need for catheter, and allow prolonged assessment more than 48 hours to increase sensitivity to detect the reflux. And also it can provide correlation between symptom and reflux, but the downside for this Bravo is just evaluate the acid reflux and exposure only, doesn't detect weakly acidic or non-acidic. And you can see here the reflux episode, and you can correlate with the symptom here. You can see the acid reflux associated with the symptoms. The rule of barium, actually, it has poor sensitivity and specificity for diagnosis of GERD, but it has an excellent to detection the restriction or rings, and only 50% of patients with abnormal reflux on esophagogram are found to have abnormal pH. So the recent guidelines would not recommend to use the barium solely for diagnosis of GERD, but you can use it as preoperative workup. Which test should you choose? Based on the recent one, the update on the modern diagnosis of GERD, Lion Consensus version 2 that published before a few months, either to use the wireless pH. The wireless pH benefit can be combined with endoscopy, no need for catheter, allow for recording for multiple days, and maybe more physiological activities, patient preference as well. But the downside for this one, as we said, doesn't look to the non-acidic one and may be confused with the swallow and reflux, and falsely choose an on-off therapy. It is more expensive, is not widely available. The catheter-based ambulatory pH testing can measure both acidic and non-acidic, can separate the swallow and reflux. It can measure the proximal extent of the reflux as well. And also it can measure the air movement, no need for endoscopy, sedation, and it's cheaper. But the downside for that one, it requires catheter, limited to 24 hours. The interpretation is more complicated and need times. So if you have patient with suspected GERD, the endoscopy was negative, that means no grade B, C, D, Paris or peptic stricture or atypical symptoms or prior to anti-reflux or persistent symptom on PPI after surgery. So at this one, we recommend to use the ambulatory pH of PPI therapy. But if the endoscopy showed the grade B, C, D, Paris or peptic stricture or prior positive pH testing, we recommend to use the pH on PPI therapy to exclude weakly acidic or alkaline reflux or overlap with the functional or esophageal hypersensitivity. How to interpret the results? It's a very important one. The interpretation, the first parameter will look for the acid exposure time. If it is less than 4%, we call this one normal or physiological. Between 4 to 6%, this one is inconclusive, but it is more than 6%, it is abnormal conclusive evidence for pathological reflux. Also, we'll look for the number of reflux episodes, either as acidic, weakly acidic, or weakly alkaline. More than 80 reflux episodes per day, it is abnormal one. Between less than 40, we call this one physiological reflux episode. Between 40 to 80 reflux episodes, we call this one inconclusive evidence for pathological reflux. The third parameter, we should look for the symptom association correlation, whether with the symptom index, that percent of symptom related to the reflux episode, more than 50% consider positive. Also, symptom association probability, this one calculated by the machine. It is more complicated than SI and cannot be calculated manually. The cutoff is 95%. Also, the other novel metrics, that's mainly with the ambulatory catheter-based post-reflux swallow-induced peristaltic wave. This need manual calculation. Also, mean nocturnal baseline impedance one. This one, they measure the electricity of mucosa at distal esophagus. This is less than 1,500 that predict response to the anti-reflux therapy. What is the role of manometry? The high-resolution manometry, actually, it assesses esophageal modus motility and anatomical landmark. It provides supportive evidence for GERD like hiatus hernia, hypomotility, hypotensive edge junction. Also will assist in the placement of the catheter-based probe, and also will evaluate for contraindication for anti-reflux surgery like achalasia. Identify the other possible etiology for refractory GERD like rumination syndrome, supragastric belching as well. And you can see here the types of the diaphragmatic hernia in this one, and you can see the what we call this one is contractile reserve after multiple rapid swallow. It is contractile reserve is present, so it is a good prognostic factor to send patient for anti-reflux surgery. Back again to the model diagnosis of the GERD by Lyon, consensus version 2. This is unproven GERD, as we said, patient doesn't have proven whether endoscopy or pH. So at this point, we should do the endoscopy and pH of therapy. If endoscopy showed grade B, C, D, esophagitis, biopsy proven Barrett's esophagus, peptic stricture, at this point, we can call this one conclusive evidence for pathological reflux. But if pH or impedance more than 6% on 24-hour study, the acid exposure more than 6% or more than 2 days of wireless, also we call this one conclusive evidence for pathological reflux. If endoscopy showed grade A or normal and pH was acid exposure between 4 to 6% in 24-hour study and 4 to 6% more than 2 days on wireless study, or total reflux episode less than 40, between 40 to 80, we call this one inconclusive evidence, and we should look for the adjuvant support for the diagnosis of GERD. For example, in endoscopy, look for the hiatus hernia or the biopsy as well. In the pH, look for the reflux symptom association, the reflux episode more than 80, main MPI as well, and the high resolution manometry. If it is done for the patient, look for the hypotensive adjunction hiatus hernia or ineffective esophageal motility disorder or absent contractility. If this one found with borderline, we can call this one conclusive evidence for pathological reflux. If it is not available at this point, you should repeat that one with a prolonged of PPI therapy. If endoscopy is normal and acid exposure less than 4% on each day of study, and total reflux episode less than 40, and main MPI more than 2,500, we can call this one evidence against pathological reflux, and you should look for the other possibility with the esophageal hypersensitivity or functional heart failure. In the proven GERD, the patient prior diagnosed with a GERD based on the endoscopy, they found the mucosal damage or abnormal pH study. At this point, if the endoscopy done on PPI therapy and showed grade B, C, D, esophagitis, peptic stricture, or acid exposure more than 4%, reflux episode more than 80, we can call this one conclusive evidence of pathological reflux. But if the endoscopy showed grade A esophagitis, acid exposure between 1 to 4%, total episode between 40 to 80 per day, main MPI 1,500 to 2,500. Look for the adjuvant if there is a hiatus hernia as well. Main MPI is than 1,500. Reflux symptom association probability as well, it is positive or negative. If there is anything with the adjuvant, so we can call this one conclusive evidence for pathological reflux. But if acid exposure less than 1% and total reflux episode less than 40 per day, main MPI more than 2,500, so it is against pathological reflux and should look for the other possible causes. The reflux monitoring for the GERD or NERD, that's the gastroesophageal reflux, if it is pathological, the pH was positive and symptom association property is positive, we call this one whether GERD based on the endoscopic find, if there is a mucosal damage or not. But if the pH is normal, but symptom association property is positive, so we can call this one reflux hypersensitivity, and the treatment for those patients is different one, and you can try with them tricycline antidepressant or SSRI. If this the pH is negative and normal pH is 4% and symptom association property is negative, so we call this one functional heart failure. I will talk briefly about the updates on the treatment of the GERD. The treatment will start with the lifestyle modification, medication, medical therapy, endoscopic therapy, surgical, and imaging therapy. So the lifestyle modification, the first one we call the patient obese, we should recommend the weight loss, and that weight loss will improve the GERD symptoms. Suggest to avoid meal within 2 to 3 hours before bedtime. Suggest to avoid the triggered food for the GERD symptoms control. Also, we suggest to alleviate the head of bed for nighttime GERD symptoms. But all these recommendations are conditional recommendation and low evidence. And so you can look for the evidence for lifestyle. All this evidence is generally weak, but we should recommend that patient
Dr. Mohammed, I'm not sure if the connection is actually having issues on your side. Seems like we are having an issue with Dr. Mohammad Alzahrani. Dr. Mohammed? Dr. Mohammed? Okay, so until we have Dr. Mohammed back online, I think he actually covered most of the very important points. One of them is actually the risk factors that we are commonly having, and that's So basically, it seems like he has an issue. He will try to rejoin us, but Dr. Mohammad Zahrani very well covered the most common risk factors for lower esophageal sphincter weakness or reflux in general, which are basically obesity, having dessert, chocolate, fatty meals, and coffee, as well as smoking and alcohol drinking. He also covered a very important thinking and approach, which is ruling out other possibilities that could lead to the same symptoms presentation, which are achalasia and eosinophilic esophagitis. Always consider that in mind whenever you're facing these patients and whenever they have a concern or suspicion that may be the underlying cause. So I think with this, we're going to proceed with Dr. Abed Lehaiby on his second topic because we are running out of time. Dr. Abed?
Yes, Emad.
Yes, thank you again for being with us today, and I would love to introduce you as the second speaker in our session today. Dr. Abed Lehaiby is well-known local pioneer of the advanced endoscopy teams. He actually worked at King Fahd Medical City, and he is today to talk about the endoscopic interventions that are applied for patients with GERD. The stage is yours, Dr. Abed.
Okay, Emad. So, Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Dr. Emad and also his team for the invitation and also to arranging such a webinar, also demonstrating live case. Thank you for Mr. George also for helping us for presenting the lectures, and also to thank all our colleagues, Dr. Mohammad Alzahrani. Can you allow me to share my screen, please? Yes, Emad. Emad, I cannot share my slides, so if you allow me to share the slides.
Abed, I think if you hit share, it should be you should be able to share.
Stated that is the host disable the participant screen share.
Okay, let me double check.
Okay. Okay, now. Yeah, that's good. You got a slide now? Okay, so again, thank you for everybody. So today my task to talk about the endoscopic therapy for GERD. So I think Dr. Alzahrani is supposed to cover the lifestyle and medical treatment and also the surgical treatment. So my job today to talk about endoscopic therapy for GERD. This is my disclosure. The objects or maybe objectives of the lecture is just to talk about mainly the right indication of endoscopic interventions in GERD patients, to talk about the unique endoscopic anti-reflux procedures. We have a lot of procedures, so we have to talk about the evidence behind the procedure and also the outcome And we'll end by summarize our talk. I will not repeat the slide, but this is very important to mention. The GERD is now the most prevalent gastroenterology disorder. At the same time, also the mechanism is different. So we have to consider that the mechanism usually is the anatomical alterations or the changes of anatomical at the G junction, weak ileus, or maybe presence or absence of hiatal hernias that play a role for all the GERD symptoms. The mainstay of management, everybody know the medical treatment and also surgical treatment. We have a good efficacy of or good response to the medical therapy. And also at the same time, we have the standard of care of correcting all anatomical abnormality by the surgical. But this is 2 points you have to understand in medical and surgical treatment. This medical, they don't reach up to high level of response, and surgical is very invasive procedure. It has a lot of post-op changes and also symptoms. That's why the endoscopic treatment now became one of the appropriate management for such a patient or select type of patients. So why that? Because the patients sometimes they don't like to be on long-term pharmacological therapy. Number two, most of the people, they have a loss of the response of the medical therapy, and they are refusing to have a major or invasive surgical procedure. As you see, this is the mechanism of the reflux, or GERD. So we have to consider a lot of anatomical changes, and then the barrier of the lower esophageal sphincters. So we have to be clear that one of the etiology. Integrity of the diaphragm, the corona of the diaphragm is also very important, and they play a role of the disease. At the same time, the presence and absence of hernia. Usually, this is the major role to correct whatever you give medications. So the medical therapy usually is not that effective or not that great effective in those type of patient. Now, this is the big survey of a huge number of patients. As you see, more than 71,000 patients. As you see, is still we have encountering a huge burden of the GERD. As you see, 40% of the adult, they are suffering the GERD, and most of them, they use medications, either BBI or H2 blocker or anti-acid. But the most important, as you see in the bottom of the slide, as you see, most of the people, they have a 50% of those people, they have a refractory, or they are loss of response, or they are not responding to the medical therapy. So we have to have another alternative to treat those such patients. I think Dr. Zahrani, he covered a lot of diagram and approach, how to approach to the GERD patients. Or let's spend time to discuss about all these diagrams and how you approach for those patients. But refractory GERD was considered one of the terminology, and the definition has been changed, but still we consider it one of the failure of treatment for those patients. So those patients, usually you have to consider another way of treating those patients. Medical versus surgical, as you see, this is a randomized. We all know, all of us know that the anti-reflux surgical is very effective, as you see here. But the problem, nobody can accept the surgery, and the post-op changes is a major. Some of them, they have a dysphagia, or they cannot have the response of loss within follow-up, or maybe they will not have a sustained response. As you compare to the medical therapy, surgical here is a way better and superior to the medical therapy, but still we'll talk about the endoscopy. Now, the endoscopic indication, as you know, is clearly that if the patient's having a hiatal hernia is less than 2 centimeters, and also you have to make sure those patients, they don't have any esophageal manometry, or they have a motility disorder. A BH is very important to prove, but sometimes the endoscopy is very clear if they have a reflux esophagitis. You don't need to have the BH metry, but it's important to confirm if you have atypical symptoms of GERD. Esophageal or extra esophageal symptoms is very clear. That is a very good to have a response for any intervention compared to the medical therapy. And those patients, clearly, if they failed medication or they have an issue with the medication, so they are one of the people to have a clear indication of endotherapy. This is one of the new AFS hiatus grade. Is very important to have a lot of combinations. This is the clear statement that is having the combination of a lot of assessment. We have to spend the time to assess your patients, either by inflating air or sucking air, or having a lot of direction, axial or the other direction, or you see the diameters or of the hiatal hernia. So we have a criteria of L and D and F. And also the most important thing to assess the flap valve. Is it present or absent? As you see here, you have a lot of the criteria to grade your patients, and at the same time it's very important to apply the best modality of treatment. As you see, if you have a grade 4, this is for sure they will not get any benefit for the medical or endoscopic therapy. Despite 1 and 2 and 3, maybe they're the best for the endoscopic therapy for those patients. Now, the team of managing those patients usually is endoscopist and also the surgeon, and also at the same time you have to have another gastroenterologist or the general practitioner to help us and our patients. Now you see the management is very difficult and changeable, and you have to select the best for your patient, and you have to work as a teamwork. And then at the end you are providing the best care of your patient. This is the endoscopic procedure for GERD patients. It's a different mechanism and different procedure. As you see, if you consider the alias augmentations for the valve of the gastroesophageal junction, we think about radiofrequency procedure. This is the strata. If you consider a transoral fundoplication, we have a 3 procedure here. One of them a TIF, and also endoscopic stapling device, and also GERDX. If you consider also the mucosal resection arms or ablation, one of the procedure you can treat your patient. Now, this is always the same. I'm telling you about the mechanism in different ways. So radiofrequency or transoral fundoplication, or maybe mucosal resection or ablation. Strata, I think there is a lot of debate about the efficacy about this procedure, and also there are few report about the procedure. But as you see here, the device is very easy to be used. You have poggy, flexible tip, and having needles to be inserted at the gastroesophageal junction, and having the radiofrequency ablations, and with time probably you have hyperactive junction to prevent the reflux. But as you see, this is they don't have a long follow-up. This is the systemic review and meta-analysis of the very good number of patients, and they have a follow-up of almost within the 28 months. They have almost a good result of patients stopping the PPI around 50%, and also reducing the erosive esophagitis about 25%. But problem, we don't have a lot of paper, and there's no much evidence about this procedure, and we don't have it as in our daily practice, or maybe it's not that popular. Now, if you think the second procedure, this one of the transoral fundoplications, the famous one is TIF, Esophyx, and also the different between the other procedure. This is clearly I will be demonstrated probably in the live case, and also I will give you some information about the procedure basically during the live case. But this is the esophagogastric fundoplications, and having a difference between the other procedure to have elongated the flap valve, and also creating a good valve around the gastroesophageal junction. If you compare to other procedure, usually they have only gastric fundoplication, so it's still the issue of the reflux is not being solved, or not be with the physiological protection of GERD. So this is one of the indication of the procedure. I will talk about this in the next slide. This is the video. I think I have to
the Esophyx technology is designed to rebuild the valve from
this video, because this will be demonstrated in the live demonstration by Dr. Emad and the live case. This is one of our live cases were done in our live endoscopy last year, just to give you a few about the procedure. Very important to have how to be a functional, or the functionality of the device, and then they will help you how to be used, and also the steps of the device, how to be performed. You need to two endoscopists, and then holding the gastroscopy, and also the other endoscopics dealing with the device. As you see, is very simple procedure. You can see and you can have a good view of the device by gastroscopy. Then you can apply your implications in the as recommended in the 11 and 07 and also 1. And then at the end of procedures, it's good to have a good evaluations of the junction, or if you have creating a good valve or very long flap valve to help your patient. As you see now, we finishing of a procedure, and then is only a few bleeding. This can be stopped within a few minutes, and then you make sure this is a good valve to be created more than 2 centimeters or 3 centimeters. This is for sure your patient get benefit, and then you can follow your patient. This is the evidence behind the procedure. As you see, this is a randomized trial, the 63 patients, okay, versus BPI. Clearly that the symptoms eliminated of 97%, and also the patient experience is almost 72%. At the end, as you see, people, they are happy to be off BPI. And this trial, the more than 90% of the TIF patient, they are off BPI. So this is one of the great achievements for our patient. This is another systemic review and meta-analysis of more than, including 32 studies and more than 14,100 patients. As you see here, the success and efficacy of the TIF is very high, of almost 99%. So they have a good scoring of the GERD and also the quality measures of the GERD. As you see, of the following, they had followed 2 and 3 and 5 and 7 years. They have a huge impact on the improving the scoring system. So it's very important to have a long data or long follow-up of data, as we have in this slide. So it's very effective, and they have a long follow-up, and also at the same times they are off PPI, and they have also, they reduce the occurrence of hernia. This is another study compared to the Nissen fundoplication. As you see, is also the patient, they have good and remission heartburn and regurgitations in the TIF patient around 66%. And most of the people, they have also good to recommend that the TIF is high probability for improving the GERD quality measures, and also followed by ARMS and then by BBI. So this is good to be on top of the procedure. Can you do it with the combination with the anesthesiological procedure? Yes, CTIF is one of the procedure can be done, and people that can have doing the procedures with a laparoscopic hernia repair. So a big debate about this trial, why you suspect the patient to do an endoscopic and then a surgical, or maybe you can decide it can be done by the surgical procedure. So it has a lot of things to consider. That is the endoscopic fundoplications is very effective for grade 1 and grade 2 and grade 3. So that's why it's very important to have non-invasive procedure, not having the long procedures, and then the result almost the same. Now, is there another indication? Yes, you can have another indication of those patients if they have hernia repair and TIF. You can do it for the patient with the Abed esophagus. If they have failed other procedure, either endoscopic or surgical, you can do it. Or maybe you consider it, as you know, now the GERD is a very big problem post either bariatric procedure, either endoscopic or surgical. So TIF or other procedure can be done before the endoscopic or the surgical sleeve. If you have a chalasia patient, it's good to follow your patient, and you can do it after you perform a myotomy if you have the patient having showing clear GERD. Now, the other type of the procedure, I will not talk much about it, but I told you this is the GERDX. So they have only one trial, and they have randomized to the 35 patients to the GERDX and 35 to the PPI. And they're reporting that is almost a good response, around 62%. But I think they have a partial response of those patients at 3 months. So it can be done And the difference between this procedure and TIF, you have to do only gastric and gastrofundoplication. You cannot do esophageal, and you cannot elongate the valve, and you cannot create a physiological flap valve. Now, other procedure can be done. We don't have any much experience about the stapling devices, and this can be done with a very dedicated device, and you have to have at least a good understanding about the procedure. So is it technically it's not that difficult, but you don't have any much experience, as you see in this video. So maybe similar to other fundoplication, but we don't have any experience in this procedure. But this is one of the studies showed that they have a good response within 4 years follow-up, around 70% of the health-related quality of life of GERD. So it's good, and the complication of those patients are not reported. We consider ARMS is one of the simple procedure, but in reality, they have major intra-procedure complications. Bleeding can happen, fibrosis can be happen, and also perforation can happen during this procedure. So it seems to be a good procedure, but you have to be ready to not creating a doing major complications intra-procedure or maybe the post-procedure. The result is very good, stopping PPI in almost around 50% of those patients. And also the complications already mentioned is around, I'm not sure what's the percentage of the complication, but bleeding and strictures is the main complication in those patients. ARMA is another procedure. So doing ablations. So the problem with those procedure, you have to use a lot of ablations, either from the esophageal side or maybe for gastric side. So you have to follow those patients frequently. You have to repeat the procedure, and you have to do it many times. And then with time, you see maybe sometimes you have a good scarring here, or probably they will be ended by stricture. So it had a good response, but I'm not sure is it practically or maybe it can be done. It's very easy to have the device. It's easy to have everything. It's very cheap, but still we didn't have any good data and follow up along data for efficacy or long term of efficacy. Now to conclude, at least to have overview about the endoscopic anti-reflux procedure, I think it's a future. For a selected type of patients. We are not competing with the surgeon, so still the surgery is there. So if you have a grade 4, this is for sure for surgery, but at least we have non-invasive procedure and very safe and very effective to treat our patient. If you compare the short operation time is very shorter, also lower complication rate compared to the surgical, and also the same times lower secondary long-term morbidity compared to the surgical or the other invasive procedure. I would like to thank the team for the invitation. This is our hospital, and probably we expect to see you at the this year, 9th and 10th and 11th May 2024 for live endoscopy, Saudi live endoscopy in King Fahd Medical City in Riyadh. Thank you. Yes, Emad. So.
Oh, thank you, Abed, for this outstanding and great presentation as usual. If we can also have Dr. Mohammad Alzahrani. Now that we concluded, I actually have one question from the audience to one of our dearest friends, actually our chairman, Dr. Emad Aljahdli. He asked a question asking, you know, when during your index procedure, you have, if I can have Dr. Mohammad Alzahrani up as video as well,
yes.
so we can, yes, there we go. Can you show your video, please? So, Abed, you know, the question directed to both of you, you and Dr. Mohammed, if at your index procedure actually found that the patient has health grade 2, which is an incompetent valve, indicating there is no underlying small or large hiatal hernia, and then with belching and hiccups, the patient may actually have a large hiatal hernia on the follow-up scope. So how are you going to approach this? You're going to consider him as healthy and you proceed with the procedure, or you actually restage and reconsider evaluating him again for this procedure? Dr. Abed, can we start with you first?
So, Emad, sorry, I was not with you with the questions. Can you repeat this?
Sure. Dr. Mohammed, have you heard the question? Okay.
Thank you, Dr. Emad. Thank you, Dr. Majid, for your question.
I'll get back to you, Abed. I have another question for you.
Yeah. Actually, the hiatus hernia is not fixed one. It looks like the abdominal wall hernia, sometimes reducible, sometimes is you can see that one big one. But when the patient have large hiatus hernia, almost this one is fixed one, and the good part of the stomach is herniated to the esophagus. So for the small hiatus hernia, especially when this one with the reducible one, I think a high resolution manometer, it is more sensitive to detect the small to medium-sized hiatus hernia, and you can see the LES valve, and you can see the diaphragmatic pressure as well, and you can measure the hiatus hernia accurately by the high-resolution manometry.
I know we had these discussions recently. We have a meeting with yourself and Dr. Abed Lehaiby and other group members at our most recent SDDF 23, and we were discussing that point, the importance of performing manometry, also pH impedance or pH capsule study included. Do you see that important before any anti-reflux procedure, whether it's endoscopic or surgical? Mohammed, do you think this is important?
Yeah, I think the most important one is to investigate patient before the anti-reflux surgery, whether endoscopic or a surgical one, by using the high-resolution manometry to assess the esophageal motility and to exclude other possible causes like achalasia, and to assess the hiatus hernia, also to look for the post-rapid swallow, the contractile reserve. The study of the esophageal motility is very important and crucial before anti-reflux that would predict to have the post-procedural dysphagia or bloating. But as you know, high-resolution manometry is not available in all in the hospital. So what we suggest to use the barium swallow study as alternative one, especially timed barium, to rule out if there is any achalasia or other possible causes for the refractory GERD.
That's very, very, very good. Dr. Abed, do you have anything to add to this?
Yeah, I think you just said that. I just usually manometry is not available, and sometimes patients don't accept to do it, even for the achalasia patients. So sometimes it's difficult to do it for all GERD patients. Symptoms usually is not that great sensitive to tell, so I think barium swallow and endoscopy probably is usually considered to do it, and very clear if you spend time to looking for the hiatal hernia or to assess the your endoscopic, good to be assessed if you have a time to assess if there is a hiatal hernia or no. But I think barium usually before the endoscopy or after, so you have to choose based on your availability. Then you consider manometry, as Mohammed said, if you think about other differential diagnosis. Another point, Emad, just to give you a clear about some of the patients, you have to guide them about the endoscopic or surgical management or medical treatment after you perform the endoscopy. If you have a huge hiatal hernia there, and it's a grade 4, so you don't spend time to give patient a lot of medication and go to that, do this, so you can send the patient. If you are in between grade 1 and 2 and 3, then you have to have a choice for your patient, and then you can have at least a clear management after you perform a good quality endoscopy and management and barium swallow.
Dr. Abed, this question to you. I know that you have touched base on ARMI, those mucosal interventions that we perform. I personally do the ARMA, and sometimes I have to do the mucosectomy. Now, the question to you, would you offer this treatment? I know it's still early and no clear results or data available enough to confirm the practicality and effectiveness of these procedures. Would you consider these procedures for certain group of population or certain group of patients? For example, I would offer it to those who have an altered anatomy, those who underwent gastric bypass. Would you offer it to a patient that never had an intervention?
Yeah, so if you talk about the ARMS or ARMAS, so I would not consider it the first step management for a normal anatomy, anatomical for a regular patient. For example, if you have a patient with the post sleeve, usually you are limited for all endoscopic treatment, especially early sleep. You cannot do TIF, you cannot do GERDX, you cannot do any surgical repair for hiatal hernia. Sometimes it's I think most of the surgeons, they know the efficacy and they cannot correct it properly, and they will not correct it correctly if patient underwent bariatric procedure, especially sleeve. So you are left by either those kind of procedure, either arms or arm. We have to consider it, and if the patient having very significant symptoms of GERD, it can't be controlled by medications. But I agree with you, some of the patient, they maybe get benefit of this kind of procedure.
Two last questions we're gonna before we move to the live case. So the first one is Dr. Mohammad Alzahrani. Dr. Mohammad, I know that when should you suspect functional disorders? I mean, is it early on in the course when the patient presents to your clinic and they manifest with certain manifestations? Is it after a trial of PPI and the patient doesn't show any significant response? Can you tell us your practical moves in that important issue? Because, you know, when we are commonly seeing patients day and night presenting with the GERD symptoms, most commonly with heartburn, regurgitation, or the feeling of chest tightness, when should you consider early on that those patients may have an underlying functional disorders? Dr. Mohammed.
Thank you, Dr. Emad. Actually, this is one of the most important one, especially for refractory GERD. But the history is very crucial on those patients. If you have patient, for example, having the psychological disorder like anxiety, depression, those patients likely found to have the functional heartburn. And the second one, a patient not, especially those patients with the typical classical symptom, heartburn, mainly heartburn, is not regurgitation. Regurgitation usually correlate with the pathological reflux, but the heartburn, chest pain, those patients, if not respond to the PPI testing after 8 weeks to 6 to 8 weeks, and then at this point should prove in the GERD, either by endoscopic mucosal damage endoscopy or abnormal pH. If it is abnormal, the acid exposure on those patients is normal, but the symptom association probability is positive with the symptom. We call this patient with having the esophageal hypersensitivity. But if the pH is normal and symptom association probability is negative, symptom index is negative, so we call this patient having the functional heartburn. The treatment for esophageal hypersensitivity and functional heartburn almost the same with the tricycline depressant or SSRI.
Well said. Now, Dr. Abed, we're going to move to the last question before we have a short break, like a few minutes before we start the live case. I know that you don't like to answer this question. If the patient came to you, doctor, is it GERDX or Esophyx? Which one are you going to recommend? You can choose not to answer, but you know, maybe you can discuss the practical point, the mechanical point of which each device. Another way, I want you to tell us how you're going to explain the two devices for the patient. Maybe we can learn from that point.
So, you know, now I think the patient now, they are very educated and they know the difference, and they know the endoscope now is non-invasive and can be applicable and can be done. So once they ask the questions, I have to go to the evidence. So I have to tell them the evidence. Then I have to talk to them or explain to them about the mechanism of the whole procedure. But at the end, I will not promote any type of procedures except the patient, they have some of the, let's say they have more information about the procedure. And believe it or not, some of the patients, they will believe their endoscopist and they will ask about the popular procedures worldwide. So then I have to tell them what is the difference in the outcome, complications, the experience of the endoscopists in the country. So if we are not experienced to do the GERDX, I will not tell them to do GERDX. If you're not experienced to do the TIF, I will not tell them to do the TIF. So if you have 3-5 people doing the TIF with an expert and they have high volume and the center is good to have a follow-up post-patient and they can treat the complications, for sure I can tell them and I guide them what your procedure can do. But in reality, most of our gastroenterologists, they believe that almost the same, but I think there is some difference. There is some different technical. For example, most of us, they believe is a GERD is a shorter procedure and the TIF is longer procedure. I didn't think so. Once we have a learning curve, you pass the learning curve, probably the time of the procedure is almost equal. And then they think that TIF is more complex and the GERD is very easy. If you have a live cases, almost they have a similar complexity of the procedure. So that procedure you have to go twice, and you have to put the wire, and you have to have a fluoro, and you have to get in. And the other procedure, one go, and then you have two endoscopists to perform the procedure. So it depends on the experience of the centers. And we discussed that the mechanism is totally different between the creating the physiological flap valve and others, gastro or esophageal gastro.
Well said, Dr. Abed. I think the whole take-home message is we are not promoting or favoring one device over the other. Actually, still data are being collected about both devices. TIF has been around in the market for a longer period, but people may find one is more convenient, easier to perform, and the others may actually prefer for the technicality and mechanism. The device is more convenient, much better. So before we have a short break, we would like, if you have any questions, please post them in the chat box and we'll get back to them. Dr. Abed, Dr. Mohammed, I will excuse you for maybe 5 minutes till we get to the case, and then we will have you on the panel for demonstration and answering questions. So thank you all for now. We finished the first part of this session, and then we're moving to the live case.
Thank you.
Thank you.
Thank you.
ايوه بس انه يعني قول لي بس اذا كنا في اللايف. Yeah. Are we on? Anybody hears me? Abed, Mohammed, do you see it?
Yeah, we are seeing you, Dr. Emad.
Okay, loud and clear, right? Well, thank you. On the second part of this session, that basically we have, first of all, we have the whole team here of anesthesia and our supportive staff. Bassem is actually working for the TIF company, and he's actually going to demonstrate the device. How do you actually handle out of the box, and what's important to be present when you do it. I have Mark is actually my assistant as a nurse. The rest of our quality team, I have Ghassan, our GI fellow, and we have the newly joined Dr. Ghufran Bukhari is our advanced fellow. We have Ashraf and the other of anesthesia team, Abdullah. Nice to have you again. Wave to everyone. All right, so we have introduced the device, but before we show you our technical or practical points here, I would just like to, yes, that's all good. So if you can bring the camera here so we can just Bassem. I know that you're the fully experienced guy with this device, and I just want you to show our audience here the part of the device, what we need to know, and it's all yours. I'm going to hand the mic to Bassem and join him as well.
Hello. Hello, everybody. Can you hear me?
Yeah, we hear you. We hear you best.
Okay, good. So this is the device, the Esophyx device, first of all, once we get it out of the package, we make sure that everything is the retroflex, and we get also the helix out of its channel. You can see that. And then we put it back. We put the helix back into its channel and we lock it. Now we start the lubrication. We need olive oil. We make sure to put, yeah, better. This is better, yeah. So we lubricate the device on top of it here all the way, and then here. Then we make sure to lubricate the device where the scope is going, and from the other side as well. Sorry, man. Yeah, but we need the oil for because it will be make it much easier while inserting. We put little bit here on the stylet, and we open this part where the loads will be sitting on. This is the cartridge which has 20 fastener, which makes it like 10 firings. And the advantage of this, it's when you are inside the stomach, you stay inside, you finish your procedure, then you go out. The cartridge sits in place, and we load it and we push through. You are able to see the serosal fuses here at the nose of the device. Then you go all the way down, and it's locked. This part here goes to the suction. The device is already lubricated. We put some gel and little bit oil on top of it, here on the top of the device, and it is ready to hand over. We clean it with the alcohol swab where the doctor is holding the device, and we hand it over to him to get the scope inside and insert it inside the patient.
We are not hearing you, Emad. We are not hearing you, Emad.
They cannot hear you.
So back to you. Thank you, Bassem, for this nice demonstration. So I just wanted to stress the point that the device has actually a channel that we can put the scope through. So actually, when you push it through the patient, the scope is already within. So now, Abed, do you have any questions? Mohammed, anything about before we proceed with the live case?
Yeah, we have a question. What kind of scope? What is the size of the scope you should use it for this device?
So they are asking about the size of the scope. Usually it's about 5 millimeter that can fit through, and you know, which we call them slim scope. Fuji has them, Olympus have them. So these scopes, they are not the regular diagnostic scope that we know. It has to be the slim scope that can put through. Others may actually use the neonatal scope, especially with the GERD device. However, you cannot apply this to TIF because you must have an invaginator and CO2 as well as suction, negative suction, which can only be done with the legitimate scopes, adult scopes, the 260s. Okay. Yeah. So okay. We're going to proceed with our case. We already have the device in the patient. I'm going to show you. Can we switch to the endoscopic image? Dim the lights, please. Okay, so Abed, do you see the endoscopic image? Abed Mohammed, do you see the endoscopic image?
Yes, I'm seeing that one. Yes.
Okay, so we're going to clean the lens. Can you make it cleaner? Okay. Now Ghassan is actually going to retroflect to see and check. You could see the device is actually all the way in the patient, as you could see here. It has two blue. Oh, yeah, that's a lot of noise. I'm sorry. So it has two blue markers. You must have both of them at least in before you consider retroflexing. When you retroflex, please make sure that you're pointing the tip of the device towards the greater curvature. So Ghassan is going to pull the scope back within the device above the second blue marker so we can make the retroflexion of, okay, so you see the first blue, pull back the second blue, and that's where we can do the retroflex maneuvering and actually can re-advance the scope again to see your position, Ghassan. Perfect. So we have the device already lined up for action. Now, the trick here is actually the positioning. You must have an assistant that actually understands the moves. We do agree on common moves that we have to deploy the serosal fuses at 7, 5, 1 and 11. At 1 and 11, you make the rotation or the fundoplication. At 7 and 5, you only make the elongation. And we're going to demonstrate that and going to show you how you do that. So I'm going to start with the 11 position.
Emad?
Yes, Abed, I'm hearing you.
Yeah, Emad, I think this is very important steps of performing the procedure. You have to understand the device. And then number two, you have to have a collaboration with your assistants. So give you the direction from right to left, and then when you place getting the helix out, and also the safety of the device when you inserting in the stomach, when you have to retroreflex, and then when you get scope out. This is the you would think is not important, but we think is not important, but this is important to understand it with your staff. And then most of the staff, they have to have at least 2 or 3 people they are understanding how to prepare the device, because
Absolutely.
not only 1 or 2 they can perform, and then during their absence he cannot perform any kind of procedure.
Absolutely, I totally agree with you, Abed. I just wanted to point out here the orientation. So the helix right now, which is that spiral needle, actually is pointing at 6 o'clock. So that's our orientation. So I'm gonna rotate all the way to 11. You can just, I'm just gonna pull it back, sorry, and loosen up a little bit the device itself. Ghassan, please follow me. So that's where actually almost 11 is, because it's flattened. So I'm gonna push the helix. Okay, right there. So you can see we're gonna make. Sorry, I'm just gonna suction a little bit. Okay, right there. Okay, follow me, so I can see what's happening. Okay, there we go. Thank you so much. There we go. So I'm gonna maybe do it right there. So I'm gonna try to always pull it back, push out so it can be straight like that. That's perfect. So once you catch the tissue, you're gonna spiral like this, trying to make more distant, please, more. So you can see we are grabbing it with the helix. We are trying to pull it down. That's what we call elongation. We bring it down. You know, the blue mark has to be somewhere above the Z line. And now we are actually, okay, we are doing the elongation. We have done this. We lock the helix. And now we're going to make the rotation. As you can see, this is very important. We have loaded them, right? All right, thank you so much. So, okay, once we feel that we are tight, we're ready to fire. We're gonna ask our colleague to put the invaginator on and ready. So we're gonna press fire. The first one has been delivered. So once is that done, don't forget to reload. Always don't forget. And you know what? Our assistant should be actually checking with us that we have done and performed that step before we even move. Make it as a habit, which should make it much easier for you to remember every time you do this. So 1 at 11 has been fired, and actually my assistant Mark is confirming that. We're going to recheck the position again. I'm going to loosen it a little bit to pull it even more. That's what we call elongation. So we elongate. Yeah, that's it. As you can see, lock the helix. No, we rotate. We ready to fire the second one, Mark? Invaginator is on. You can check the harmony and the coordination we're performing. And we fired the second at 11. we reload immediately. You know, I have to tell you, the procedure takes much shorter than that. But today because we are demonstrating this, we have to speak it loud every single step we're doing. So I'm actually approaching to deploy the third serosal fuse, and I'm gonna just relax it even more. And that would be actually the last to deploy at 11. Rotate, fundo, suction, invaginator on, and we fire the last at 11. And we reload. Any questions, Abed, Mohammed, anyone from the audience? Invaginator off. So we can actually now release the helix as we have done this part.
So how many fasteners you put it here, Dr. Emad?
So at 11, we usually deploy 3. At 1, we deploy 3. At 5 and 7, we deploy 2 at each spot. So I'm just, okay, this is released. We're going to move. You could see the coordination between me and my assistant. We have to be very coordinating. We loaded, right? Oh, okay. So see, that's the importance of having an assistant. Little blood is not a big issue. You know, it's tamponading it as long as it's not severe bleeding. We have loaded. Now we're gonna target 1 o'clock. As you can see, we're gonna release. Okay, there we go. Maybe a little suction could help in this spot. I'm trying. Okay, that's it. That's it. Okay, you could see that we are okay. Always, whenever you can reach it, that means you have to go higher. Okay. The target usually for me is actually the Z line. So I'm trying to get the Z line. Sometimes if you see it's actually very tight. No, insufflate a little bit more. Insufflate a little bit more. Okay, insufflate a little bit more. Okay, there. Sorry, I'm gonna, yes, there. There we go. Could see that we are actually nicely got 1 here. Okay, retroflex. Okay, let me see it well. And now we're gonna pull it even more. Okay, now this is not really good. So we're gonna yeah. There we go. That's better. There we go. Sometimes you have to pull it in again. Okay, now let's stay in position so I can just grab it as it is. I'm sorry, I'm a little bit needy here. There we go. Always target, pull the helix in so you can actually, once you grab the tissue, just pull it away, open the mouth wide so you can bring the tissue down to the level where you can actually grab it. That's very nice one. I'm gonna lock the helix at this point and start closing and rotating. Okay, stay as you are. Okay. Once I feel like I'm actually section, yes. Once I feel like I'm in position, I can just vaginator on, and we fire the first serosal fuse. 1 on at 1. We're gonna reload and push again. Each one of us is doing his part here. Okay, and now again, I'm just gonna pull even more after I relax the jaw to bring it in. This is, again, fundoplication with elongation. So we have to pull down a little bit. So suction, please. Opa. So I think we lost the helix. So adjust your wheel. Okay. Okay, good. That's fine. We can just redo it again. Okay. You can always fix it. No problem, no issues. Open the jaw. You could see that we have to open, bring it even closer, closer, closer. It may appear bloody and messy, but that's fine. Okay, so we're gonna rotate. That's good. Suction applied. Invaginator on. We're gonna fire the second round. Fired. And we're gonna reload the third set of the rows of fuse at 1. So Abed, any comments, any questions from your end? We're almost finishing here. Abed, Mohammed, I hope I did not lose you.
Yeah, we are following you, Dr. Emad.
We're almost reaching the end on this. Reaching, yes.
Okay.
There we go. Last round of serosa fuse at 1. We do the fundoplication, which is the rotation. There we go. We tighten it. Suction and invaginator on. And we fire the last set. So we finished at 1. We relax, we loosen the helix and release the tissue. So now we are left with the 2 elongations at 5. So we finished 11, 3 serosa fuse, 1, 3 serosa fuse, and now we looked up with 7 and 5. We'll just do 2 each, and that's the end of the procedure. So that's supposed to be easier. No more rotation. Just pick up your side, pull the helix in, and push it out. So you can just get. Oh, I did. I reloaded. Are you sure? Okay. See, that's the point. When you have assistants like Mark and Ghassan, that can overcome your denial issues. When you're getting older, that's how you fix the problem. Okay, Abed, I know I'm just talking about myself. Okay, so can you show me better? Can you show me better? Oh, okay, there you go. That's better. Okay, I'm gonna. Oh, sorry. Pull it in. Yes, Abed, I'm listening to you.
How to overcome usually the issue with the helix? Usually you have to grab like a good piece of tissue to control it or to pull it up.
So the helix itself is actually challenging in a way that sometimes there's so much tension applied by the device itself, suspension of air. So you might just need to take your time, choose the right spot, and you know what? It's just very important that you just be patient. Every time you grab it, don't apply too much force. At the beginning, you might just need to bring it closer to you. You fire like here. So I'm because of so much tension.
Maybe imagine this case, probably if you pull back the device a little bit, and then you will be very closer to the junction. It will be very easy to have a good tissue.
Yes. So that's what I'm doing right now, Abed. It's just like the helix itself is kind of, I need to bring it closer to me. There we go. So I reorient. There we go. Once I screw and I get the tissue, I relax the arm and then I pull it towards me like that. So that's the way it is. So I instruct and that's how I bring it closer to me. So when you pull, you just hide the second blue. The second blue should be above your line. So I'm gonna fix it here. I'm not gonna apply too much tension because I just want to fix it now. And that's the first one. Vaginator on. We're gonna fire the first. I'm gonna reload.
Okay, Emad, another issue. Do you have to be aware that the CO2 of the device is different, totally different from the CO2 of the scope?
Yes, so, absolutely.
So they have to have the
external insufflator, which we call the surgical insufflator.
And then usually from surgical department, you can.
Absolutely, I totally agree. So we fired the last at 7, and then we are left up with 5, and that should be done in no time. We're gonna reload the last 2 canisters or serosal fuse. Reload. We're almost, inshallah, we're gonna be finished in less than 5 minutes.
Emad, did you listen to your assistant, or you are doing the job by yourself?
No. I listen to them all the time. Trust me. I honestly here, I have to tell you that. Can you go? My assistants are actually very competent, and they do a tremendous great job. I almost cannot function without having them by my side in any procedure. And you know what? You have to, and you know it very well, Abed. You know, when you train those assistants to any certain procedure, it takes time. Can you interpolate and show me better? Okay, suction. Yeah. And you know, it takes time. Distend. It takes time, and that's how you invest in them. You really invest in them.
Good. Are you using the gastroscopy or pediatric gastroscopy?
The slim
Adult?
upper scope, yes.
Oh, that's good.
I want to see, yes, like that. Clean your lens. We are like the last few. Okay, we got it. Relax. We got the last rows of fuse. There we go. Oops. Okay. Oh. This scope is, yeah, in my way. Okay. Once we grab it, as you can see, we relaxed, so we can bring the tissue even closer to me, like you see it. There we go. And we lock it. And then that's the elongation. We fire. Invaginator on. Vaginator off. We relax, we reload, and then fire the last 2 serosal fuse. And that's the end of the procedure.
Emad,
Yes, Mohammed.
can you remind the audience the patient selection criteria for the TIF?
Yeah, so basically, those closer and distant patients actually should be, they have failed the trials of PPI, or if they have developed side effects from PPI, or if they're not compliant with PPI, and to the point that you're actually using a lot of vaginator on, we fired the last, or they're not compliant with the PPI. Those patients actually, when you confirm the presence of GERD, by all means, all recommendations and guidelines are recommending that performing endoscopic anti-reflux or even surgical anti-reflux would be of a great improvement to their. Okay, just 1 second, Mohammed. I'm just okay. Yeah, there we go. Pull. Straighten, pull. Okay, we're gonna just. Okay, push. Okay. One thing before we move, make sure that the helix is actually locked. As you could see here, I can see it at 11. Wait. It's not out yet. Okay, there. So it's locked and secured. We're gonna pull the whole device out, and then we're gonna go in again. Push the scope. Okay. Yep, and we're gonna pull the whole thing out, and we're gonna go in and examine. So, yes, going back, you can stop this noisy machine. So going back to you, basically, what we, Mohammed, going back to your question. So if the patient is not compliant, if the patient has side effect from the PPI, if the patient is not having the optimal, PPI that was actually invented years ago or 2 decades before, they can only manage some of the GERD symptoms, such as heartburn or chest tightness. But the actual reflux state, or the regurgitation, or suffocation, coughing, sneezing, upper respiratory tract symptoms, asthma, sinusitis, cannot be managed by simply PPI. You must reinforce the lower esophageal sphincter. And that's where endoscopic anti-reflux management come in place. GERD, TIF. Today we perform TIF. We do that. We actually tighten and elongate the lower esophageal sphincter to a higher technical success and higher clinical success. Those patients actually, right after the procedure, they can report that the regurgitation, which is the main and major complaints they had, actually has improved after they performed the procedure. You can just look at this. The widely patent lower esophageal sphincter is actually tighter. The fensters, the serosal fuse are in place. We're gonna measure now. This is a 35 centimeter, where the tightness starts, and push down, push down, push down till here. This is, we are talking about 3 centimeters. It's about 30, from 35 to 38. This is 3 centimeter elongation of the valve, which creates a high pressure zone that will increase the resistance to intragastric content to habit. You could see this wrap around. You can clean it. It will show better. Do you see the endoscopic pictures, Mohammed?
Yeah, we are seeing that one. But if you can clean it,
you could really appreciate that we have elongated. There is a donut tightness around the sphincter itself. Don't be misled by the around the scope area, because this is not the high pressure zone. This is just an area below the serosal fuse, but the serosal fuse are applying the high pressure zone. Elongation has been achieved, 3 centimeter elongation. We have downgraded Hill class from 2 to 1 because we have gained at least 2 centimeter elongation. And you know what? Other things, patients, we admit them for observation overnight. We cover them with antibiotics for 7 days. We keep them on liquid diet tomorrow if they have, starting tomorrow if they have any issues. And then PPI for a month. And after that, I see them usually 1 week after the procedure, then 1 month, then 3 months, and 6 months, and 12 months. So far, we have done quite a number of patients, and all of them, except one, actually, I have to be honest, had demonstrated great results. The first one, actually, that has failed because he developed bad corona infection. Upper respiratory tract, he has been coughing, which really did bad to these serosal fuse. We have redone the TIF, and now he's actually enjoying it. Just a side note, he said he's very happy because he was able to eat al-bake again. That was his biggest concern. That's very interesting, right?
Yeah. Just a question about the adverse event for this TIF.
Yeah.
Safety of the TIF, is it safe one? What are the complications from this procedure?
Oh, so you know, out of the 20 cases we have done so far, the only thing they report is just tightness at the upper abdomen, which is explained by the edema, hematoma, and the recently deployed serosal fuse. But this completely subsides within 10 days' time. Every day is better than the day before.
Emad,
But thankfully, no bleeding, no perforation, no upper chest or actually shoulders pain, none of that.
Emad, our experience, our patient, they have a chest pain. It lasting for sometimes a week. So I'm not sure how we can make sure there's no something touching the pleura, or maybe an abscess, or this is a normal pain post procedure.
So it's just Abed, this could be the epigastric pain they complain about, or the lower chest tightness they report. But in few of them, we ended up doing CT scans just to make sure like they don't have any perforation, and none of that actually showed anything to be concerned about. It's just the serosal fuse, when they are deployed, they create the tension in the area that would lead to such feeling. And you know what? We all agree these things disappear in a matter of few days.
Okay.
Weeks,
So
maybe 1 or 2 weeks.
Another question, Emad.
I'm sorry to cut you, Abed. They all respond to Panadol and light pain medication.
Sure.
Section, and come.
So, Emad, is it necessary to keep the patient on PPI for 3 months or less or more?
Usually, I would keep them for 1 month, which is the recommendation, simply because, I would consider having the serosal fuse in place almost like distal esophageal ulcers. When they are exposed to acid, it just provoke more pain, and that's why the PPI can actually help decreasing that feeling. Also, you know what? It just like maybe the symptoms of chest tightness and upper abdominal pain could improve with the PPI on board. Do I have patients who really did not follow the recommendation and stopped using PPI in the first week? Yes, I do. They did not really have serious symptoms. They just have the tightness I reported because of the intervention itself.
Okay.
Any questions from the audience? I'm happy that you were able to show this demonstration. I really thank my colleague, my fellow Dr. Ghassan and Dr. Bukhari, as well as everybody is on board. And please, if you have any questions, we have the two of the pioneers in the field, Dr. Abed, Lehaiby, Mohammad Alzahrani. We'll be more than happy to answer any questions you have.
Emad, I have one. I need your comment. I have one patient, so came to me
Yes.
after.
I'm Abed. Abed, before I'm just gonna put you on the picture. I'm gonna change and see you at the other side on the laptop.
Sure.
So anesthesia can do their job here. Thank you.
Thank
I'll
you.
see you there.
طلعوا صورة عابد ومحمد. طلعنا الحين كفيديوهات.
يا سمعت.
يلا حطنا. بسم الله. Yes, can I have Abed back to
Maybe
you?
question also for Mohammed.
Man,
yes. Do you need to dilate before or?
Yes, as a matter of fact, we use the savory dilator, especially in a smaller patient, because that will facilitate pushing the device down. If you have difficulty, you may need to deflate the balloon, the endotracheal balloon.
15 or 18?
Yes. The dilation?
Yeah.
I use the large savory. I think it's about 40. The largest one, so I can just have the maximum dilation. It's one of the bougies, external bougies we use.
Okay.
Any questions from the? Okay.
So nothing in the chat.
Yeah. Well, I think I really think we have a good case done today. I really thank you for joining us today and for delivering the outstanding lectures about the approach and the management and endoscopic management options we have. We had a great case of TIF demonstrated today. If you have any questions, please feel free to email us on the email. Dr. Abed, Dr. Mohammed, super thanks to you and to the supportive team and the company sponsoring Nuzha Medical, and looking forward to host you in more events. Hopefully next time you'll be in person here, no more remote streaming. So if you have anything to say, please proceed.
So Emad, thank you, Emad, again. Also, thank you, Mohammed. I think it was great to have such an event, and I hope to at least to provide the evidence and also treating one of the common gastroenterology disorder and worldwide.
Thank you, Dr. Emad. Thank you, Dr. Abed. I think this is one of the great events showing the change in the diagnosis and management of the GERD. What have done before 10 years, different now, totally different from what have been done from 10 years back.
These devices are game changers, and I'm sure more and more interventions will come out. people are kind of moving away from the surgery when it's not indicated. We still have those patients with large hiatal hernias who actually deserve to have a surgical repair before we commit doing any of these interventions. I thank you again and looking forward to see you in great events. Dr. Abed Lehaiby has a great event, live endoscopy in May, and hopefully we'll see you all in there. I know that he's shy to advertise for this one, but I will take the behalf and the actually motive to do that. And looking forward to have you all in that event.
Thank you, Emad. Thank you, Mohammed.
Thank you. Thank you.
Have a
See you.
wonderful day. Take care. Bye-bye.